All right, welcome back, everyone. Let's just dive right in, shall we? In our last session, we laid all the basic groundwork, defining what drugs are, where they come from. Today, we're taking that theory and we're finally applying it to real, on-the-floor clinical decisions. We are tackling the fascinating logistics of how medicine actually enters the human body. We're looking at pharmacology pathways, and honestly, by the end of this explainer, you're going to see drug delivery in a completely new light.
Here's our roadmap for today. Just a quick 6-step syllabus to completely demystify how medicine gets into the bloodstream. We're going to map out the highway, face the liver checkpoint, break down our enteral, parenteral, and topical routes, and then wrap the whole thing up with a master recap table. Let's get moving.
Okay, Section 1, the drug delivery highway.
Think of the human body like this massive, complex map. The absolute final destination for almost any systemic medication, it's the bloodstream. So imagine a delivery truck trying to get there. You've got the IV route, that is your high-speed, direct interstate highway. Boom, you are instantly at the destination, no traffic. Then you've got the oral route. Taking a pill is kind of like taking the scenic back roads. Sure, it's easy, it's super common, but man, it takes a long time, and there are a ton of stops along the way. And finally, you have these sneaky little shortcuts, like the sublingual route under the tongue, which just bypasses the heavy traffic altogether. If we put these routes in a visual race, IV finishes first, sublingual takes a really clever shortcut, and oral just takes the long, slow way home.
Moving on to Section 2, the liver first pass checkpoint. So why exactly is that oral route so agonizingly slow and complicated? Well, it all comes down to the first pass effect. When you swallow a pill, it goes into your gut, it gets absorbed, and then it gets sent straight to the liver before it goes anywhere else. I always like to think of the liver as this incredibly strict airport security checkpoint. It rigorously screens all the cargo coming in from the gut. It literally metabolizes or breaks down a huge chunk of that drug before it ever reaches the systemic circulation. Because of this heavy security screening, the drug's bioavailability, meaning the actual amount of active drug that makes it to the bloodstream, is significantly lowered. Let's look at the long way in our little visual race. Step 1, you swallow the medication. Step 2, it processes in the gut. Step 3, it hits that heavy liver security checkpoint we just talked about, where a ton of the medicine is completely dismantled. Only after surviving all of that does it finally reach Step 4, systemic circulation. Don't get me wrong, it's effective, but you are losing a lot of the drug's raw power along the way. Now, contrast that long, exhausting journey with the sublingual shortcut. By placing a medication under the tongue, it rapidly absorbs right through that incredibly thin mucosal tissue and goes directly into the bloodstream. It completely avoids the gut. It completely avoids the liver security. It crosses the finish line of our visual race incredibly fast, retaining its full active power. All right, Section 3, enteral routes, or the gut pathways. So enteral essentially means involving the gastrointestinal tract. Think your standard oral pills, or the buccal and sublingual pathways in the mouth. But hey, let's test your critical thinking really quick with a mid-explainer clinical quiz. Ready? Imagine you are working on the floor. A patient is having a massive heart attack and needs chest pain relief in literal seconds. Which route are you going to choose? The oral back roads? The IV highway? I'll give you a second to think about it. If you guessed sublingual, you absolutely nailed it. And this brilliantly illustrates our theory in a very real, very high-stakes scenario. The classic clinical example here is nitroglycerin. When a patient has severe chest pain, we pop a nitroglycerin tablet right under the tongue. It uses that sneaky shortcut we just talked about, totally bypasses the liver's first pass effect, and delivers fast, life-saving action directly to the heart. Okay, I want you to literally pause the explainer right now and screenshot this. This is your enteral mnemonic flashcard for your upcoming exams. OSB, Overcome Stomach Barriers. That stands for oral, sublingual, buccal. Got it? Awesome, let's keep moving. Section 4 already? Parenteral routes, basically the bypass lane. So if enteral means via the gut, parenteral basically means beside or outside the gut. These are your injection-based routes. They are the ultimate bypass lane because they completely 100% skip the gastrointestinal tract and that annoying liver first pass effect. And speaking of 100%, that is the magic number for parenteral routes, specifically the IV or intravenous route. Because you are injecting the medication directly into the systemic circulation, IV provides exactly 100% bioavailability. Zero drug is lost to liver security.
None. That is exactly why IV is the absolute fastest, most reliable gold standard used in critical emergencies. But IV definitely isn't the only parenteral route. Let's play a quick round of clinical would you rather. Would you rather get an intramuscular, or IM, injection that goes deep into the muscle, hurts a bit more but works really fast? Or would you rather get a subcutaneous injection right into the fat layer, which is way less painful but offers a much slower, steady, prolonged absorption? Let's do another quick quiz to see how you'd apply this. If a diabetic patient needs a slow, steady, controlled release of medication throughout the entire day, which route do you choose? That's right, subcutaneous. Insulin is the absolute classic example of this perfect clinical match. And speaking of the IM route, here's a highly shareable real-life clinical pop-in for you. Did you know vaccines are given via the intramuscular route precisely because it avoids that first-pass effect while providing a really steady, reliable absorption for your immune system to react to over time? That is exactly why you get your flu shot deep in your arm muscle instead of just swallowing it as a pill. Let's actually map these out visually because it helps so much. Imagine a body map. Point to your own arm or thigh right now. That's your target for intramuscular, or IM vaccines. Now imagine the very top surface of the skin. That's intradermal, the absolute classic route for allergy testing and TB tests. Point to your knee joint. That's intra-articular, where we'd inject drugs like hydrocortisone to directly treat severe, localized arthritis. Mentally mapping these specific routes right onto your own anatomy, it's a massive cheat code for retaining this information on test day. All right, screenshot time again. Pause the explainer and grab this bold text mnemonic for the parenteral category. Injections vary in many specific clinical instances. IV, IM, SC, ID. I'll give you just a second to snap that. Moving right along, Section 5, Topical and Transdermal Routes. Okay, we've covered the gut, we've covered the injections, now let's talk about medications applied directly to the body's surface. The absolute key distinction to remember here is surface versus patch. A basic topical medication acts locally, exactly where you apply it. Time for our last quick quiz. If a patient has a localized eye infection, what route gets the medicine exactly where it's needed without flooding the rest of the body? Topical, like antibiotic eye drops. But a transdermal patch, that is brilliant for a totally different reason. It's designed to deliver a continuous, slow release of medication literally through the skin and into the systemic bloodstream over hours or even days. Classic examples you'll absolutely see in practice are nicotine patches to help folks quit smoking and those little scopolamine patches they put behind the ear to prevent motion sickness. And here is your final opportunity to snag a study mnemonic for today. TT, touching tissue for topical and transdermal. Save this to your camera roll. And finally, Section 6, the Master Route Recap Table. We have officially reached the grand finale. We've covered a massive amount of ground today, and this table brilliantly illustrates the whole shebang in one place. You've got your enteral route via the gut, heavily subject to the first-pass effect, with our classic shortcut example of sublingual nitroglycerin. You've got your parenteral injections bypassing the gut entirely, perfectly demonstrated by subcutaneous insulin and IM vaccines, and you have topical and transdermal applications like the scopolamine patch. I'm going to hold complete silence for 5 seconds. Please pause the explainer and screenshot this comprehensive recap table right now. Ready? Go. Okay, before we go, I want to end with a provocative thought experiment to really spark your clinical curiosity. If you had to design a brand new drug for instant, completely painless delivery, what wild new route would you invent? Are we talking a smart inhaler, a dissolving microneedle patch? Comment your crazy ideas below. Also, do me a favor and comment which route from today's session you found the most confusing. I will personally clarify it in our next explainer. Keep studying smart, you've got this, and I'll see you in the next one.